Alzheimer's and Parkinson's and other traumatic brain injury, PTSD, other disorders, including the neurologic consequences of COVID-19, where we believe this also has applications. Okay, let's see. Now we need to go. Oh, I see. Okay. So before I go into my talk, I want to just simply disclose that there are a number of patent applications that my employer, which is a nonprofit, not-for-profit, nonprofit health maintenance organization, has filed on our work. The first one was filed in 1989 when I first came up with the idea of bypassing the blood-brain barrier by giving therapeutics intranasally. And the second one was really a patent specifically about using intranasal insulin to treat Alzheimer's and Parkinson's. Both of these patents have long expired. Then more recently, we have patents related to using intranasal insulin for post-traumatic stress disorder and traumatic brain injury. Also, we have patents related to the intranasal delivery of therapeutic cells, primarily stem cells, but also NK, like natural killer cells for brain tumors, things of that nature. And we have also patents filed related to using iron binding drugs to treat brain disorders. Now, for so many years, people have said to me, why is it taking so long to develop a treatment for Parkinson's and Alzheimer's and, these other degenerative diseases? And I think we are all aware that the blood-brain barrier, which is a good thing because it protects the brain, potentially our most important organ, that this is a good thing, but the side effect of the blood-brain barrier is it really limits the kinds of therapeutics that could be delivered to the brain. And yes, and that is a big problem. Also, we know that when you administer drugs, either orally as a pill or by injection as a shot, that this can lead to numerous adverse systemic side effects, because once you load up the bloodstream with a drug, even if you only really need it in the brain, there's nothing to prevent that drug from going to the liver, the kidneys, the heart, and the lungs. So in order to get approval of therapeutics, they must be not just effective, but also safe. So we first proposed and developed this intranasal solution to the blood-brain barrier problem. And the clue that we got to do this came from a very unusual dream that I had in 1989. So at that time, we were trying to use neurotrophic factors and things that could increase the health of brain cells, signal cells to replace their worn out parts, increase brain cell energy. And we were very frustrated because these things, when given orally or intramuscularly or what have you, just simply were not getting into the brain at the levels we needed. And I went to sleep and I had a dream in which I was arguing with other scientists. And I was saying, the natural therapeutic proteins that the body makes, things like nerve growth factor, brain-derived neurotrophic factor, insulin-like growth factor, or insulin, these kinds of things I thought would be helpful for treating Alzheimer's and these other disorders. And of course, in my dream, the other scientists are saying this will not work because of the blood-brain barrier. And every one of us knew in the 1980s that there were harmful things that could get into the brain if they got into the nose. People knew that if you swam in polluted water and you got amoebas in your nose, like Naegleria or acanthamoeba, that you could die of amoebic infection of the brain. People knew that in Chile, when they mined manganese, the dust would get in the nose of the miners and they would become hypomanic. And there were other examples. And really, the only idea that I got in the dream was this very simple idea. If bad things can do it, why can't good things do it? So I woke up from the dream, and before I started doing experiments, I decided I would file a patent application in 1989 on the use of intranasal delivery to bypass the blood-brain barrier and target drugs to the brain. And this method, of course, is very different from what others had been doing. People had been looking at boring a hole in the skull and injecting drugs directly into the parenchyma, or giving drugs into the cerebrospinal fluid intrathecally or intracerebroventricularly. But we were very focused on this direct connection from the nasal cavity to the brain along the olfactory nerves, the cranial nerve 1, and also along cranial nerve 5, the trigeminal nerves. It was my graduate student at the time who also suggested the trigeminal pathway as an alternative that may be involved. And what we found from doing experiments in animals was that this was totally non-invasive, that we could bypass the blood-brain barrier and deliver peptide therapeutics and small molecules and other things to the brain. We also found out that the delivery was very rapid. In less than 10 minutes in animals and in 10 minutes in humans, intranasal therapeutics would reach the brains of the animals and could reach the cerebrospinal fluid of the humans. And in order to be that fast, we realized that this did not involve axonal transport. It did not involve the drugs going into the primary sensory neurons and being transported to the brain intraneuronally along the axons, but rather it was an extracellular, paracellular delivery of the drugs flowing along the olfactory and trigeminal axon bundles to the brain, up through the foramina or small holes in the cribriform plate, into the subarachnoid space. And of course, if it were the trigeminal nerves, it would go from the nasal mucosa where the trigeminal nerve endings are to the trigeminal ganglion, and from there could go to the subarachnoid space or more caudally to other areas in the back of the brain. Once in the subarachnoid space, these therapeutics can then follow the blood vessels of the brain, the cerebrovasculature, but they are following the cerebrovasculature on the brain side of the blood-brain barrier. They are not in the blood compartment. They are flowing through the perivascular spaces that surround the blood vessels of the brain, that separate the blood vessels from the parenchymal tissues of the brain. And when the heart beats, it pulses blood through the lumen, through the vessels of the brain, and this creates a peristaltic perivascular pump that pushes the perivascular fluid along with these drugs rapidly throughout the brain. So, for example, in animals, we know that if you give therapeutics intranasally, you can find them not just in the olfactory bulb, which may be the first part of the brain exposed to the river of drug flowing past it, but you can find the drugs in the cerebellum, in the upper cervical spinal cord, very quickly after intranasal delivery. So this method not only can allow you to deliver therapeutics to the brain that don't cross the blood-brain barrier, but also you can reduce or even sometimes eliminate systemic exposure and unwanted side effects if the drugs don't go from the nose into the bloodstream. So now I just will talk for a minute about Alzheimer's disease. If you take a look with fluorodeoxyglucose PET scans at a normal elderly adult, which you can see on the right side of your screen, you see that blood sugar, glucose, is taken up and metabolized very actively in a normal, healthy brain. This is a person in their 70s. But if you look at a person who has Alzheimer's disease, who's the same age, the same gender, you see very little uptake and metabolism of glucose. Now, of course, it has been taught in medical schools for many decades that the brain is insulin independent. It doesn't need insulin. And yet this, we believe, is not the case. And so if your brain cells are not taking up glucose, the main energy source for brain cells, then you will have a number of very important problems. We know that insulin signaling is reduced in the brains of people with Alzheimer's. And when you combine this with insulin resistance, you end up with this cerebral glucose hypometabolism that you saw in the picture on the previous slide. This has been called diabetes of the brain by Suzanne Delamonte at Brown University and by others, Hoyer in Europe. And this leaves the brain cells starved for energy and unable to function normally. Without energy, not only can the cells not function normally, but they cannot synthesize the parts needed to replace those that become damaged or worn out. Thus, the brain will degenerate and there will be a loss of function. So our discoveries covering the intranasal delivery and targeting of insulin to the brain to treat Alzheimer's and Parkinson's were followed by multiple human clinical trials. To begin with, there were 5 clinical trials that were done in Germany, originally at the University of Lübeck and then later at University of Tübingen, showing that in normal healthy adults, intranasal insulin improves memory and does so without adverse side effects. And that is, of course, by comparison to placebo-treated controls. With intranasal insulin in these 5 clinical trials, there was no change in the blood levels of insulin or glucose. But we do know that in normal healthy adults, you can see insulin go up in the brain within 10 minutes after intranasal administration, as shown by Jan Born in 2002 in his paper called Sniffing Neuropeptides. Also, we know that intranasal insulin safely increases brain cell energy, and that includes levels of both ATP and phosphocreatine. And this has been shown in normal healthy adults using MRI, but phosphorus 31 MRI, not just regular proton MRI. And obviously, contrary to traditional teaching, the brain is not insulin independent when it comes to increasing brain cell energy or glucose metabolism. We then there have been a number, 6 clinical trials in people who have either mild cognitive impairment or Alzheimer's disease. And these have shown improved memory following intranasal insulin treatment, again, with no change in the blood levels of insulin or glucose. The first trial we published in 2006, I had found Suzanne Kraft at a neuroscience meeting in San Diego and told her about my intranasal insulin treatment. And so we collaborated and she carried out this study. In this particular study, there was no specialized nasal spray device. She simply took up the insulin into a diabetic's insulin syringe and then cut the needle off the barrel with a pair of scissors and had the patient put their head back and dripped it into the nose. And that was the method of administration. Many of the subsequent trials used nasal spray devices, but there is still a lot of question about what is the best device, what is really the best way to administer insulin to the brain in human trials. and what is really the best dose of the insulin. The doses have ranged from 10 units per side to much higher levels. Also, the type of insulin can be important. We know that with patients who carry the ApoE2 or the ApoE3 gene alleles, that they do show improved memory with intranasal regular insulin, things like Novolin or Humulin, or even rapid-acting insulin. But patients who have the ApoE4 gene, which increases their risk for Alzheimer's, only really have shown improved memory with intranasal long-acting insulin, insulin Levemir, Detamir. So intranasal insulin most recently was shown in a clinical trial to actually reduce white matter hyperintensities in the brains of people with Alzheimer's. And this was through MRI. And we know that white matter hyperintensities can, in some cases, indicate cerebral small vessel disease, which could be significantly associated with an increased risk of stroke. Now, consistent with what I've told you about increasing insulin in the brain, leading to increased insulin signaling being beneficial, we know that people who have type 2 diabetes have twice the risk of getting Alzheimer's disease. Again, not surprising since diabetics also have insulin resistance and a deficiency of insulin signaling. We believe human studies are needed to determine if intranasal insulin can reduce the risk of getting Alzheimer's in this high-risk group, the millions of people who have type 2 diabetes. We do know from one clinical published trial by, I think, Vera Novak, that intranasal insulin did improve memory in individuals with type 2 diabetes who did not have Alzheimer's. And we believe this same treatment may be beneficial to those who have type 1 diabetes and are experiencing what is called hypoglycemia unawareness. This is a very dangerous condition that can actually lead to death. And in fact, my first cousin's oldest daughter, who had type 1 diabetes, died of hypoglycemia unawareness. So this is another potential use to prevent that of intranasal insulin. More recently, a study done in combination between Harvard and University of Massachusetts has shown that intranasal insulin also helps to preserve verbal fluency and memory in people with Parkinson's, and it improved movement and reduced physical disability in those Parkinson's patients when compared to baseline. So this was a pilot study that they published. We have our own study of intranasal insulin going on now in people with Parkinson's. It has been interrupted and delayed many times over the last 2 years because of the coronavirus pandemic. Also, many of you are familiar with the fact that deep brain stimulation has helped a number of people who have Parkinson's. And one of the things we know that DBS does is to increase glucose metabolism in the brain. So this is consistent with the finding that intranasal insulin is beneficial in Alzheimer's patients. In Parkinson's patients. Now, people who have had coronavirus and did not die from it have experienced persistent functional symptoms and complaints after recovering from the respiratory problems associated with this. And they have also been shown to have a continuous hypometabolism in various brain regions, glucose hypometabolism. We know that intranasal insulin treatment targets brain hypometabolism to increase brain cell energy and memory, improve white matter integrity, reduce inflammation. And of course, COVID is an inflammatory disorder. And so we believe that a clinical trial to treat post-COVID-19 patients who have these persistent symptoms like brain fog and anosmia should be done. We have never had the money or the ability to do that trial, but we would certainly like to see that trial done. Also, intranasal insulin, we were able to show in collaboration with the Uniformed Services University in Bethesda, Maryland, we have found that intranasal insulin improves memory and increases cerebral glucose uptake, decreases neuroinflammation and hippocampal lesion volume in animals that have had a moderate traumatic brain injury and in animals that have had multiple milder injuries or concussions. So we believe that this should be tested in humans. We have been trying for the last 3 years to get the funding to carry out a human clinical trial of intranasal insulin in individuals with concussion and traumatic brain injury. So far, we have not received the money that we have asked for. There are other conditions and disorders that we also believe intranasal insulin will be beneficial for. We know that in adult men, it was shown in 2008 by Boehringer and his colleagues in Germany that intranasal insulin greatly attenuates the hypothalamic pituitary adrenal axis response to stress in adult normal men. And this leads to reducing cortisol. And we believe this can help to treat or prevent the development of PTSD following a traumatic event. As you may know, PTSD is not a disorder that usually occurs immediately after a traumatic event. There is a delay in the development of PTSD symptoms. We also know that PTSD is greater, the risk for it is greater in people who have TBI. And we know that intranasal insulin, at least in animals, can treat TBI. Epilepsy also involves decreased glucose uptake and metabolism, and decreasing brain glucose metabolism can cause seizures in animals. And we therefore believe that clinical trials of intranasal insulin in individuals who have seizures are warranted, especially those who are refractory to treatment with other epilepsy drugs. Something that many people do not realize is that Alzheimer patients actually have 10 times as many seizures as healthy controls of the same age. The reason this is not recognized is that the seizures that occur in Alzheimer's do not occur in the motor parts of the brain, in the movement areas of the brain, but rather are occurring in the memory areas of the brain. So the benefits of intranasal insulin in Alzheimer's may in fact be mediated by their effects on these seizures, for all we know. Further, we are interested in the use of intranasal insulin to treat individuals with anorexia nervosa, in which glucose hypometabolism is very prevalent, as well as hypercortisolemia. So, and we know that intranasal insulin can act to counteract these things. Further, in people with anorexia, there is increased insulin sensitivity, which means that the intranasal insulin should be even more beneficial in these individuals. Now, another aspect of brain disorders that has gotten less attention is the abnormal accumulation of iron and free heme in the brain. We know that iron accumulates abnormally, as does free heme in Alzheimer's disease, also in Parkinson's, stroke, traumatic brain injury, FTD, Lewy body dementia, all of these disorders. Obviously, we all need iron, we need hemoglobin, but free iron and free heme are very damaging to the brain. They promote the production of free radicals through Fenton chemistry. catalyzed by iron that results in an inactivation of the human brain muscarinic cholinergic receptor, which is required for memory, and also of other key brain components required for movement and normal brain function. In animals, intranasal, I'm jumping ahead here. Fortunately, there is a generic drug called Deforoxamine that binds iron at very high affinity, 10 to the 31st power. And this has been used to treat systemic iron overload in the blood of humans for many years, people who have beta thalassemia, sickle cell anemia, et cetera. There was a 2-year clinical trial in patients with Alzheimer's disease in which this iron binding drug was given intramuscularly. And that was found over 2 years to reduce decline in the Alzheimer patients by 50%. But there were significant adverse side effects. Also, there is a very short half-life of about 20 minutes in the bloodstream, and this drug does not easily cross the blood-brain barrier. So we have developed intranasal Deforoxamine to treat these disorders. And in animals, we have found that intranasal Deforoxamine, the iron-binding drug, reduces memory loss in a mouse model of Alzheimer's, and that it actually improves memory in normal, healthy mice, making their memory better than that of normal mice. The mechanisms involve, obviously, the binding of iron, reducing oxidative damage, but intranasal Deforoxamine also increases hypoxia ischemic factor 1 alpha, and it increases the phosphorylated form of glycogen synthase kinase 3 beta, and the expression of insulin receptors. So in animals, intranasal Deforoxamine not only improves memory in normal mice and in Alzheimer mice, but it also treats both the genetic alpha-synuclein model of Parkinson's and the 6-hydroxydopamine toxicity animal model of Parkinson's. When Deforoxamine is given intranasally 2 days before middle cerebral artery occlusion, a stroke in rats, or given after stroke and reperfusion in rats, it actually reduces the amount of brain damage by 55%. And the animals that get the nose drops of the iron binding drug do not get paralyzed and do not die compared to the placebo group. So this is a very powerful intranasal treatment. So as funding becomes available and FDA approval allows, we will be conducting clinical trials of intranasal Deforoxamine in people with Alzheimer's, Parkinson's, and other brain disorders. We already are looking at a small study simply to intranasally administer the drug and measure it in the CSF in humans as an initial way to go into humans with these treatments. Now, Dr. Lucine Danielin, who is originally from Armenia, but working in Germany and University Hospital of Tübingen in Germany, has shown with us that stem cells obtained from bone marrow of adults, when given intranasally, bypass the blood-brain barrier and specifically target only the damaged areas of the brain in animal models of Alzheimer's, Parkinson's, and other brain disorders. These cells are like little doctors. They can detect where the damage is because of the release of inflammatory markers from the damaged area. And they can, by chemotaxis, target those areas. So when you start with a unilateral 6-hydroxydopamine model of Parkinson's, where only the substantia nigra and striatum are damaged on one side, and you give those animals intranasal bone marrow-derived stem cells, all the stem cells only go to those areas. The other side of the brain, the stem cells do not migrate to. And these cells are very anti-inflammatory. And when administered, let me go to the next slide. When administered, as you see in the top row here for treating Parkinson's in this model, Not only do they eliminate the inflammation and the pro-inflammatory cytokines, but once they get to the area where the dopamine brain cells are damaged, these cells, which come from bone marrow and have never produced dopamine, they don't even have the enzyme tyrosine hydroxylase to make dopamine when they're in the bone marrow. But in the brain, they realize this is what is needed. And now they express the gene that produces the tyrosine hydroxylase that synthesizes the dopamine, and they release it. They also produce brain-derived neurotrophic factor, which is protective of dopamine brain cells, and they release that, and the animals begin to move normally. So this is very exciting kind of new approach to regenerative medicine. Similarly, in Alzheimer mice, Dr. Danielin has shown improved memory, decreased soluble amyloid, et cetera. We're not personally, I'm not very interested in amyloid. We've never worked on amyloid, even though we've been in the Alzheimer field for 40 years. But this approach has been used by Cindy van Veldhoven in the Netherlands and others to treat neonatal brain damage, neonatal ischemia. Also at Emory University by Dr. Wei to treat stroke. In Sweden, Dr. Fransson has actually delivered a different kind of cell. These are T regulatory cells to treat MS. We and others have done intranasal stem cells to treat brain tumors, a lot of that done at the University of Chicago. And in Japan, they are looking at treating spinal cord injury with intranasal mesenchymal stem cells. Now, finally, we believe that these anti-inflammatory stem cells, when given intranasally, can be beneficial for the treatment of the neurologic consequences of COVID-19. We know that stem cells, we know that the virus accumulates in the nose. And the stem cells, of course, would be given to where the virus is accumulating. We also know that from the nose, the virus can go through the nasopharynx to the lungs and lead to acute respiratory distress syndrome and the production of an inflammatory cytokine storm, both in the nose and in the lungs. But the virus and these cytokines in particular can also transmit from the nose to the brain. Now, there have been conflicting reports about the virus being able to travel from the nose to the brain, even though many viruses since the early 1900s, I think since 1902, have been found to travel from the nose to the brain. But with this COVID-19, the SARS-CoV-2 virus, some people have reported the virus does go to the brain, others have claimed that it does not. But the inflammatory cytokines, TNF-alpha, interferon gamma, IL-6, there is no doubt that these small peptides can easily travel from the nose to the brain. And if they damage the oxygen sensing respiratory centers of the brain, that could cause you to stop breathing. And of course, if they damage the olfactory areas, as they travel along the olfactory nerves and go into the olfactory bulb, that could lead to anosmia. If they damage the hippocampus, that could certainly lead to brain fog. So these are significant problems. Now, in addition to acute inflammatory brain damage, there will also likely be long-term neurologic consequences of COVID-19 infection, which intranasal anti-inflammatory stem cells could address. People seem to forget that many of those who survived the 1918 viral pandemic went on years later to develop Parkinson's disease. So intranasal anti-inflammatory stem cells delivered directly to the area where the virus accumulates in the nose may be able to help to treat and prevent both the acute and long-term brain damage associated with COVID-19 and its pro-inflammatory cytokine storm. Hopefully, these intranasal adult stem cells can function as the fire trucks, the camiones de bomberos, chasing after the pro-inflammatory virus and its cytokine storm as they migrate along the olfactory and trigeminal pathways into the brain. And our intranasal approach to treating CNS disorders in general can greatly expand, we believe, the kind of molecules and biologics that can be used to treat brain disorders while increasing the safety and efficacy of that treatment. So that is my presentation, and I'm hoping that we can discuss this further, and I'm happy to answer any questions that you may have.
Thank you very much.
Thank you.
Very much, William.
Okay, hold on for one moment. Okay, now I have a picture again.
Okay.
Yes.
This has been an exciting talk. Let's start with the interventions. Miguel Cruz, Oscar Sánchez, ¿quieres intervenir?
Sí, por
Miguel
favor.
Cruz primero, después Oscar Sánchez.
Well, William, thank you. Thank you. It's very exciting when you talk about intranasal insulin treatment. I remember when I attended the ADA meeting and the first conference of this approach to control the glucose in patients with type 2 diabetes, and was amazing because people was thinking, wow, this is the solution. Instead of injected insulin, you can just take the insulin through the nose.
Yeah.
But
Yes.
one curious comment, when you use insulin in the skin, do you notice in patients that is darker? Because in patients, well, in general, when you have hyperinsulinemia, you have acanthosis nigricans in the neck, on the other parts of the body. So I was thinking, is that possible? Do you have any evidence when patients use long time period the insulin?
Okay, so let me see if I can answer. To begin with, the idea of using intranasal insulin to treat diabetes so you do not have to inject, this idea was pursued by administering insulin in a formulation that would intentionally damage the epithelium of the nose. Because if you did not damage the epithelium of the nose, the insulin would not go into the bloodstream. So that is a very different kind of intranasal insulin than what I am speaking about, because first of all, there is no effort to deliver the insulin high up in the nasal cavity anywhere near the olfactory epithelium. If you're trying to simply get it into the bloodstream, then the nasal mucosa is surrounded by many blood vessels. And if you can damage the epithelium of the nose, the insulin can go into the bloodstream. Of course, we are not wanting it to go into the bloodstream. So we do not formulate it with anything like that. We simply take the insulin. Unfortunately, the drug companies do add preservatives to the insulin. So if a diabetic individual leaves the insulin out on the countertop and forgets to put it back in the refrigerator, nothing will grow in it. But that does not damage the epithelium to get it into the bloodstream. So those are two very different things. Now you are also asking secondarily about, does the insulin damage, you are asking, does the insulin damage the epithelium of the nose?
Yeah.
So far,
yeah,
so far, no one has reported that it does. And we do, when we do intranasal treatments in animals, sometimes we do send the epithelium of the nose for toxicological analysis to determine, has the drug damaged the epithelium of the nose? We ourselves have not actually done that with insulin. We have done it with other when drug companies come to us and they say, we have a drug, it won't cross the blood-brain barrier. We want you to see if it can be given intranasally to the brain. We will look and see when you put it in the nose of the rat or the mouse, does it go to the brain? And we may also look to see, does it damage the epithelium? But because so many human trials have been done and no one has reported seeing any damage to the epithelium, I'm not sure if anyone did this exact study that you were at to answer the question you were asking about.
Okay, thank you. And the other question, briefly, we know that insulin, when attached to the insulin receptor binding, you have different signaling. One is to stimulate the GLUT4 to up the intake glucose into the cells, and there is growing. So according with your experiments, and as you said, no differences in insulin and glucose in the body. So it's more the signaling in growing cells, repair some cells, and that's the explanation why you have the benefit when you have different diseases like type 2 diabetes or the others that you mentioned.
I'm not really sure that I understand the question. I know that, I mean, we did, in animals, we have labeled the insulin with, I think, fluoro gold, and shown that when you give it intranasally, we can follow it into the brain, and we can see it going into the olfactory bulb and into the nucleus of the cells and things of this sort. But I don't really, maybe you can try to ask me again.
For example, when you have the insulin binding to the insulin receptor, many signaling into the cells, IRS1 and ETC, and finally GLUT4 goes into the membrane and take the glucose from the blood. But in brain, there's another pathway of insulin signaling, or what is the consequence that you say benefits in patients?
I don't know the answer. I don't know. We have not really looked at those signaling pathways ourselves. I believe that there is a paper by Suzanne Delamonte from Brown University about the question that you are asking, but we have not looked at it, and I don't remember the details of what she reported.
Okay, well, thank you so much. Sorry, I have another meeting, but nice to meet you, and thank you everybody, Javier, and all of you. Please keep contacting us, and if you have any ideas or you would like to do something with us. Have a good day.
You. Thank you.
Gracias, Dr. Cruz. Encantado de que esté aquí. Let's following with Oscar Sanchez Escandón, please.
Thank you, Doctor. Dr. William. Thank you for this new point of view of the therapeutic approach to the Alzheimer and Parkinson disease, and as we can see, an other kind of neurological problem. It's clear, taking your ideas about the vascular system in brain that is so unique and follows special rules that are different in the systemic vascular system. And that's why we ask some special thing talking about the pathophysiology in Parkinson disease and Alzheimer disease. As we know, in this problem, we understand that we have problem with the lymphatic system. You know,
yes,
this is the accumulation of huge quantity of beta amyloid or B amyloid and tau protein. How is possible that the intake by nasal vessels insulin could help to recover this function?
okay.
When in these patients are special, affected with this.
Yeah.
problem.
Okay, let me say a few things. To begin with, intranasal insulin, when it reaches its target and it signals to the cells by binding to insulin receptors, the body wants to eliminate the insulin after this signaling occurs. It is similar to a neurotransmitter is released into the synaptic cleft, and it signals on the postsynaptic membrane. And now the body wants to get rid of the neurotransmitter with, let's say it's acetylcholine. Acetylcholine esterase gets rid of it. So the next time a signal comes, you can see the release of presynaptically of the acetylcholine.
Yeah.
So with insulin, after it causes signaling, in order to eliminate the insulin signaling causes the production of insulin-degrading enzyme,
Okay.
IDE. This is the main enzyme that degrades beta amyloid.
Okay.
So if you do not have insulin signaling, you will accumulate amyloid.
Okay.
Because you do not have insulin degrading enzyme. And even in the Alzheimer transgenic mice, which the very first Alzheimer transgenic mouse was produced by Karen Shaw Ash at the University of Minnesota. She is in my department of neurology. And even in these models, these transgenic models, before amyloid accumulates, there is a decrease in insulin signaling.
Okay.
So yes, these models have amyloid, these animal models have amyloid, but is it the amyloid that actually is causing this disease? I don't think so.
Okay.
So this is one factor. Now, another factor is that insulin inhibits glycogen synthase kinase 3 beta, the enzyme that phosphorylates tau to form Alzheimer tangles. This is inhibited by insulin signaling, insulin. So there are effects of insulin that can lead to changes in tau and lead to changes in amyloid, processing and degradation. In addition, amyloid binds iron. Specifically, we published a paper with a number of other researchers showing that there is a binding site on amyloid for free heme. And it is only the species of animals that have amyloids with the heme binding site that can develop Alzheimer's. These are humans and polar bears, and I forget which species they are.
Mammals, no?
Yeah. But there are mammals that do not have the heme binding site, and they do not naturally develop Alzheimer's. Yes, you can genetically alter them to accumulate amyloid. Okay. So these are complicated things. I'm not sure. I probably forgot to say things that I was going to say, but that may be part of the answer. I know that, even to demonstrate the toxicity of amyloid, there are papers that suggest that if you do not have iron, it's very hard to demonstrate the toxicity of amyloids. Or if you have a free radical trapping agent, it's difficult to demonstrate the toxicity of amyloids. So, this is sort of all related to your question, I believe.
Thank you.
Sure.
Thank you.
Gracias, Oscar. Rodolfo y después Gabriela, por favor. Y después Gustavo. Rodolfo.
Gracias. Thank you, Dr. Frey. It was amazing talk. I only have one question. You have talked a lot about insulin, intranasal insulin, but you were answering to Dr. Oscar Sanchez about how insulin can decrease tau phosphorylation. Have you have you studied about if this decrease in phosphorylation is associated to a decrease in the activity of GSK3 beta?
There is some evidence to this effect, and I believe, I don't know whether I sent you to Javier, I don't know if I sent you an email about intranasal insulin. It would be in the title of the email, but I can send it to you. But I believe in this email where I summarize the mechanisms of action of intranasal insulin, I believe that I refer to the effect of insulin itself, rather, on GSK3 beta and phosphorylation of tau. But I believe that or you can just Google, you can search for intranasal or just search for insulin and glycogen synthase kinase 3 beta. That would be the way to do it. We have not ourselves looked at that. I know we have looked with, or if we have, I don't remember. I know we have published about Deforoxamine increasing phosphorylation of GSK3 beta, which means reducing its activity.
Yeah, reduce the activity. Oh,
yeah.
That's incredible.
So we have shown that, but I don't remember if we ever actually did the study with insulin.
Thank you for the answer, because it was a little bit of my concern when you answered, Dr. Oscar. It's really amazing, and all the studies are really interesting, and also the COVID results are. It's interesting to understand or trying to find the aspects of COVID fog, so brain fog. Yeah.
Yes.
Thank you about all of this.
Thank you. And let me say also, I do not mean to suggest that we have cured Alzheimer's.
No.
We believe that cerebral glucose hypometabolism and the abnormal cerebral accumulation of iron, brain iron accumulation, we believe these are two important problems associated with the disease. You might call them biomarkers. We believe they are more important to address these than to try to, just remove amyloid. We are quite convinced by the 6 pharma companies that each spent $20 billion to produce drugs that reduced amyloid, that did not help Alzheimer patients, that is not the way we should be going. And we are grateful that we did not go that way ourselves.
Thank you very much.
Gracias, Rodolfo. Gabriela.
Thank you so much for your presentation, Doctor. I have a couple of questions regarding with the intranasal insulin, as you say, for the treatment of Alzheimer. We know that another part or another mechanism for eliminate beta amyloid is, for example, the endothelial cells through the LRP1 transporters that get impairment in this pathology, as well as in type 2 diabetes. After the treatment with insulin, it is known that this this transporter get improvement, or there is just the cognitive measurements.
I do not believe that someone has reported what the impact is on that transporter. I do not recall seeing a paper where someone has looked at, it would be good to do that, but I don't recall seeing that in the literature, that someone has looked at the effect of insulin on that transporter, intranasal insulin, in animal studies.
Yeah, because could be, I mean, could be so interesting, because the blood-brain barrier, 99% of the capillaries on the brain and in the brain. So there are two mechanisms. There are the reducing in this receptor, in this transporter, and in an increase in this receptor advanced glycation
Yes.
that go up and another up. So I will
That's a
think
good
that
question.
maybe insulin can nivellate those.
So certainly the insulin, certainly the cerebral vasculature is going to be exposed directly to the insulin, because this is the pathway, even though you're on the brain side of the blood-brain barrier. Exactly. The blood vessels are right there, and and the insulin is flowing along them. So there is a good chance that it may have an impact on the transporter, but I just don't recall anyone looking at that. One of the things about, now I remember something. Someone asked me about the lymphatics, and I forgot to mention, and this is what I forgot to mention, is that the nose has the nasal associated lymphatics, And in the neck, we have the deep cervical lymph nodes. And from the nose to the brain, through the roof of the nasal cavity, there are lymphatic channels in humans. So there is an entire lymphatic pathway from the deep cervical lymph nodes to the brain. And when you intranasally administer substances, certainly they go into these lymphatics. And so, because a lot of these brain disorders involve inflammation and the immune system, microglia, which can be pro or anti-inflammatory, et cetera, So these are all important aspects of what may be involved in the action of intranasal cells or intranasal insulin or what have you. Yeah.
Okay, and another very short question is that, as we know, the first stage of, for example, type 2 diabetes or even Alzheimer disease have this insulin resistance. And the proposal is that there are resistant for the transport from the blood to the brain. But eventually, in these neuropathologies, the neurons also can get this insulin resistance. So in this way, the treatment of intranasal insulin get a limit, is a stage of Alzheimer patient in which this treatment is not effective anymore?
Very good question. Very good question. Certainly that is possibly true. And one of the things that I see in development, because I deal with lots of other researchers and groups around the world, is that there are people developing treatments specifically for insulin resistance, to treat insulin resistance. And those treatments would likely be synergistic with intranasal insulin for the reason you just pointed out. And so eventually we may be looking at combining not just maybe an intranasal iron binding drug like Deforoxamine with intranasal insulin treatment, but also hopefully something that is going to reduce the insulin resistance and allow the intranasal insulin to be more effective.
Thank you so much.
Yeah, a good question.
Gracias, Gaby. Gustavo Pacheco.
Yeah, thank you for a nice presentation. I was wondering, because in your talk, you basically elaborate around insulin, intranasal insulin into the brain, but you don't claim that is neurons. I think maybe you were so cautious to avoid mentioning that it's a neuronal effect. If you would elaborate on that, and in particular, because I think everyone is aware that insulin receptors dynamics are fluctuating along the day, and in particular, preparing food intake. So olfactory bulb get enriched of insulin receptors just minutes before we are used to eat. So this rhythm is really important. So my question is this really important, the timing of the intranasal administration? So have you elaborate around the particular timing when it's appropriate?
No one has really looked at that. I suspect that you are correct, that timing is important. And certainly the insulin receptors in the olfactory bulb and in the hypothalamus are very, going to be really important in terms of eating and metabolism. But I don't think anyone has actually looked at it. The part of the problem is that the funding for anything that does not have to do with amyloid has been almost non-existent for 40 years. I mean, it's like, at least in our country, if you have a treatment, and we have seen this time and again, and it doesn't matter if you improve memory, they don't really care. The funders, the grant reviewers, if you tell them you have a treatment that non-invasively, without any adverse side effect, improves memory, they say, well, that's all well and good, but that's not a disease-modifying therapy because you didn't get rid of amyloid, or you didn't show that amyloid, whatever. It's very hard to get funding for these trials. And therefore, people limit themselves dramatically in terms of the things they look at in people, because these clinical trials are expensive. You can spend certainly 600,000 or 1 million or 2 million on a clinical trial, and it's very hard to do if you don't have the money. So if someone like the paper we did in 2006, Suzanne Kraft and I, Dr. Rieger, the first author, if they administer a certain way or do a certain thing, then people just keep doing the same because they know that's going to produce an effect, and then they look at some other aspect of it or what have you. It isn't that no one ever thinks of trying different things. It's they don't have the money to try it.
Yeah.
Honestly, this is my view.
Maybe just a comment, because I'm curious on the vehicle of insulin. People for years claim that insulin smell, and we know that insulin does not have any odor. It's P-cresol, the vehicle itself. So we have been trying to formulate the correct vehicle, but it's honestly impossible if you are not inside of the pharma industry.
Yes, that's
what are your vehicles? So what's your vehicles? How you control?
Well, we believe, first of all, if you are familiar with Sjogren's syndrome, dry eye syndrome, you know that initially, first of all, Sjogren's occurs primarily in women, primarily postmenopausal women. People have dry eyes, they itch, they burn. Can be very serious. And initially, these drops that were produced all had preservatives. But it turns out the preservatives are irritating. So now, when people have dry eye syndrome and they buy these Tears Naturel or Refresh or whatever it is, most of them are preservative free. Many of them are unit dose. And, ideally, if we are going to do intranasal insulin, ideally, we want an insulin that does not have these preservatives. These preservatives are damaging to the nose, to the brain. Over time, they have to cause some irritation, et cetera. And in fact, one of the preservatives in one of the insulins is the same substance used to clean the autopsy table after they drag the body off at the end of the autopsy. I forget which insulin and which preservative, but it's the same chemical. And so in my opinion, ideally, you want a unit dose insulin without preservatives. And yes, there is a smell due to these, and it creates a problem when you have a placebo-controlled clinical trial. How do you keep everyone blinded, you know? So but here's the thing, once you start changing the formulation of the insulin, then the regulatory agency comes in and says, oh, well, this is not the same as this generic drug that was approved. And they want you to answer all these other questions. Now, do you have the money? You're not a drug company. Do you have the money to do all these things? Also, we have contacted the producers of insulins, Novo Nordisk, Eli Lilly. Many years ago, Eli Lilly sent a delegation to our labs, and we told them about intranasal insulin. We asked them to collaborate with us. And they said, no, insulin is our diabetic drug. And they had some of their insulin people come and visit with this delegation. And we're only interested in insulin for diabetes. We know that if we just reduce amyloid, that's going to treat Alzheimer's, and that's where we're spending all our money. And we tried to convince them otherwise, and they would not, we were not successful. But my point is, none of them, not a single one, not Novo Nordisk, not Sanofi, none of them had any interest in intranasal insulin for treating brain disorders. And that's where this stands. Now people are starting to look at, intranasal insulin. For example, we know that older people who have surgery and are exposed to anesthesia, that the anesthesia exposure can reduce their memory and cognition. We know that neonates that have to have multiple surgeries can have very significant problems because of the anesthesia exposure in these surgeries. And intranasal insulin appears to prevent this. So there is a clinical trial that the Canadians are going to do that was funded by an Alzheimer foundation to test intranasal insulin for preventing memory loss and cognitive decline due to exposure to anesthesia. There are people looking at, after heart attack, you can have coronary, after a coronary, you can have brain problems. What about treating with intranasal insulin? There is a clinical trial looking at this. There are many trials that people are starting to look at with intranasal insulin. But the problems that you point out are very real problems, and there's no easy solution if you are not a drug company.
Oscar, por favor.
Sí, rápidamente. So fast, doctor. Well, I have a question talking about the treatment. If we consider that the main biomarker for to evaluate the improve is what shows the patient, or in this case the model animal, are the memory and cognition. How long lasts this effect? How you can have the main observation to say that this is useful in clinical?
Yes. So that is such a good question. And I think the answer has to do with, let's look at both insulin and let's look at the deforoxamine. So we look at two different things. We know that if you take a person, and we have many in our society, we may have the world's record, but if you take a person who develops type 2 diabetes, and the endocrinologist says, you actually need to take insulin, and I want you to take it twice a day, and they take the insulin, we know that after they take the insulin 3 or 4 days, They cannot stop taking the insulin.
Sure.
They're just, it's not going to help them if they stop. And in many ways, I see what's going on in Alzheimer's or in Parkinson's or these cerebral glucose hypometabolism disorders. I see it in that way, in that they must continue to take the insulin. Now, if you look at and I'm not saying that that will always be the case, but if you look at the Deforoxamine, the intranasal Deforoxamine is a kind of ischemic preconditioning. It basically, I believe, it causes signaling when you reduce iron, increases hypoxia-ischemic factor 1 alpha, and you're removing probably the iron that has accumulated. And there is a very good chance that you can treat and not have to treat every day with this drug, because you have caused a kind of signaling that has altered gene expression and that has removed the accumulation of the iron and done various things. So I think that, these are different kinds of mechanisms, different kinds of drugs. And I think that the necessity to continue treatment is going to be different. Of course, you look at donepezil, or you look at Namenda or some of these other drugs. People have to keep taking these drugs every single day. Yeah. And if you take Aricept or donepezil and you take it for a month or two, and it seems to reduce the decline, and now you stop, immediately the patient doesn't just stay the same, they go back to where they fall dramatically to where they would have fallen in their performance had they never taken the drug. They're back with the placebo group. So, those are not good solutions either. You know this as well as I do. So I mean, I don't know. I'm not sure what else to say, And of course, the stem cells are a completely different thing. The thing about the stem cells is that if you give stem cells by injection into the brain, you cause inflammation with the transplantation, and it kills the stem cells within hours or days. When you give stem cells intranasally, those cells go into the brain to the right area. They are still living 6 months, 7 months later, functioning in the brain like the little doctors that they are. So it is possible that this kind of treatment may actually be a much more effective way to be a long-lasting treatment than some of these others.
Okay. Thank you, Doctor.
Gracias, Oscar. Enrique, adelante.
Thank you for the talk, Dr.
Yes.
William. I have one question. Is there a maximum dose of intranasal insulin that cause negative effects or brain damage?
Yes, such a good question, such a very good question. So if you look at the human data in people with Alzheimer's, which Suzanne Kraft, my collaborator way back in 2006, 2008, whatever, and she published trial in 2012, it appears that in normal adults who do not have ApoE4, so that these are responding to regular insulin, you do not need long-acting insulin, it appears actually that the dose response curve is biphasic. In other words, if you have a graph, I'm not sure, let's do it this way. If you have the y-axis and the x-axis, and the dose is increasing along here, there's, of course, at 0 dose, there's no benefit. This is benefit. Now you start to increase the dose and the benefit goes up, goes up, goes up. It appears that then the benefit goes down as you increase more, down, down, down. So it is like an inverted U upside down U almost. So yes, this is what this appears to show. Now, if you look at normal healthy adults, which the German researchers have primarily done, they use very high doses of insulin and they still get benefit. They can use 160 units, whereas the Alzheimer's studies generally use maybe 40 units as the top dose or something. So it is really unclear. If you look at the animal model studies, and there are some intranasal insulin mouse and rat studies, I believe that they show, and I don't remember what kind of models these were, but I believe they also showed a biphasic sort of response where it goes up and then comes down. So, but this is still not totally understood or agreed upon, Also, we know that when you're looking at the effect of insulin on appetite, in normal healthy adults, insulin in normal adult men that are not obese, insulin reduces body weight and body fat when given intranasally. But in obese men, it does not. It does reduce snacking in women, intranasal insulin in humans, in women. But, there are different things like gender and body weight and things that can also have an impact on what insulin does given intranasally. So these are questions that still need to be answered, I think. But I thank you for bringing that up because it's very important.
Gracias, Enrique.
Yeah, de nada.
Thank you.
Gracias, Enrique. William, if you allow me, I have two rapid questions. One concerning the intranasal insulin. Have you any recording of the emotional response besides the cognitive response?
Yes.
That is last question. And the other is the regarding the Deforoxamine and stroke. Sounds like a very promising manipulation, no?
Yes.
Can you tell us
Yes.
more about it?
Okay, sure. Stroke and hemorrhage, both. So there is one clinical trial which reported improved mood in people who got intranasal insulin. They felt just better. I don't know if I want to say happier or what. I was not involved in the trial. It was done in Germany. And I don't remember if it was by Benedict or someone else. I don't recall, but definitely they showed improved mood. But the problem, they also showed improved memory. And I believe and I don't recall if this was a rapid acting insulin like insulin Novolog, it might have been. Insulin aspart, or which is, I think, Novolog. But I think that what happened is people were so excited about memory, they ignored the mood. They ignored this improvement in mood. But you might imagine, we know that brain cell energy goes up with phosphorus 31 MRI, where you see high energy phosphate. It's like ATP. In normal adults, we see that increases. It wouldn't be surprising if when your brain cell energy is increasing, you feel like your mood is better. Now, certainly the intranasal deforoxamine, we have a neurologist who specializes in, I believe he is very interested in hemorrhage. I think he's like a critical care neurologist or something. I forget the whole story, but I think he is going to be looking at intranasal deforoxamine in hemorrhage. There have been studies looking at hemorrhage and stroke where people have given deforoxamine, I think, systemically. And there are a number of these big trials. One of them, I think, is called the high def for Deforoxamine trial or something. But they have not had good success in those trials. And of course, when we have gone to the people who run those trials have gotten a lot of money. And we've said to them, why don't you do it intranasally? Oh, they think that's very amusing, but they're not going to do it. So, we are tolerated. A lot of the work that I have done through my 44 years is barely tolerated by the establishment.
Well, thank you very much, William. There's no another participation, so I would like to thank in behalf of my colleagues. I think this is this has been a wonderful talk, and I guess that this will be the start of a collaboration if you allow us.
I hope so. I hope so. Let me just end by saying something about my first visit to Mexico. I didn't tell you this already, I don't think, in a previous thing, but when I was 12, my parents took my brother, who was close in age to me, to Mexico, and we went to Mexico City. And the people were incredibly nice to us. I could actually speak conversational Spanish quite well when I was 12. I was good then at language, but when you don't have a chance to practice and decades go by, it's difficult. So anyway, they took us to El Palacio de Bellas Artes, and what an amazing place it was for us. And we went in, and I remember going from room to room and looking at the paintings. And of course, I was very taken by not just the muralists who are more in other places maybe, but by many of the artists. And we came into a room, and there was a guard, and we saw the paintings there. And then we went by ourselves into the next room, and we're looking at the paintings, and we look up and we see right between two of these fantastic paintings, a giant tarantula on the wall. At 12 years of age, I was frightened. So we rushed back into the previous room. We grabbed the hand of the guard, my brother and I, and we drag him into this room, and we point at the tarantula on the wall. And he laughed and laughed, and he said, that is our tarantula, and he is our friend, and he makes sure that no other insects or anything else bothers our paintings. Anyways, I never forgot that experience. It was just the first of many great experiences we had on that trip. But someday when the pandemic is over, I hope to come back.
Yeah. We will be very happy to have you near to our group. I think that after your talk, several views have been started, and we will back to you as soon as possible. I'm sure if you allow us to do that, because you mentioned some areas in which we are very interested and we are working on. So let us digest your talk and think about it, and we will come to you as soon as possible if you allow us. Thanks to technology, we have this chance to have this kind of seminaries. So we will be very near to you and to your work and to your group.
Good. And let me say, Javier, that you are very encouraging to me too, because it's good to see someone who's probably close in age to me that has maintained their enthusiasm. And people say to me, Bill, aren't you going to retire? What's the matter with you? And I go, I'm not going to retire. I love this work.
They don't let me to retire.
Good.
No,
So I will be here for a long time. I
Good,
hope.
good.
Well, thank you very much to everyone. Thank you very much, William Frey. It has been a pleasure to be with you. Oscar, ¿quieres decir algo?
yes, doctor, we're glad to having you again. We're, as Dr. Velasquez said, we are very interested in working on these topics. And of course, if you let us or allowed us to get a kind of communication, we'll be very glad to do it. Thank you so much, doctor.
Thank you very much. Nice to meet all of you.
Thank you very much, William. Gracias a
Thank you so
todos
much.
y nos estaremos convocando a una próxima reunión, un próximo seminario. Gracias.
Bye.
See you soon.
Bye,
Doctor.
bye.
Bye.
See you.
Bye,
Bye
bye.
now.
Doctor Velázquez, ¿puedes esperar un segundo? Y
¿Quién?
Joali, doctor Velázquez, Joali y el doctor.